الحمد لله الحمد لله. Okay. Ask for control.
Yes, sir. One second.
This case, elderly patient, suspected stroke. You can scroll and tell me what are the findings.
Yes, sir. I've been provided with axial section, CT brain. So,
At the start, you can use one click only, then scroll or up and down keys.
so it's not happening.
I will do it for you. No problem. No
Yes, sir.
problem. Okay. يلا, let's see.
I've been provided with axial CT, axial section of CT brain non-contrast images. I'd like to see the entire stack of images. Okay. So the striking feature that I can see is cerebral age-related cerebral atrophy and periventricular hyperdense areas could represent chronic ischemic changes, and I can see a chronic lacunar infarct in right basal ganglia, and
Patient has suspected acute stroke. I'll make it easy. Okay, right-sided hemiplegia.
okay,
But general, my friend, general. Just a general question. If you faced
yeah.
a normal appearing CT scan in the brain, because involutional change is considered normal for age, what are the hidden areas you are looking for?
Sir, I'm looking for gray white matter differentiation loss if there's some infarct or
Good,
bleed, if there's
good.
any bleed, or if there is if it's normal, then I look at the MCA to look for any hyperdense MCA sign,
Good,
or
good,
the basilar artery to look for any basilar artery
good.
hyperdensity, or if it's a young patient, I look at the venous sinuses to look for
Excellent,
distension of the
excellent.
venous sinus.
Any hyperdensity. Very good, very good, very good. This case, yes, it's hidden, but history can guide you. Right-sided hemiplegia. So,
Okay.
any
So
subtle
the
finding?
so
You are
transverse
looking
sinus.
to the right or left?
I'm looking at the left side, sir.
Yes, yes.
The MCA looks
Compare.
compared to okay, compared to the right side, the left MCA looks hyperdense,
Slightly hyperdense.
slightly
Yes, yes. Very
hyperdense.
good,
Yes,
very good. It's very subtle, and
yes, sir.
comparison is essential. Good. Anything else?
So apart from that, I'm not able to visualize any other gray white matter differentiation
Good,
loss in any of these visualized sections. But there's age-related cerebral atrophy
good.
and
Uh,
chronic
so,
ischemic changes there.
what you are suspecting and what to do next?
Sir, I would suspect a non-hemorrhagic stroke, acute non-hemorrhagic
Good,
stroke. Then I would ask
good.
for a immediate MRI brain with diffusion.
Actually, MRI was not available in this unit. What you will do next?
So CT angio should be performed, sir.
Okay. Now, let's start from down up.
Yeah, I've been provided with CT angiogram images of brain. The okay, the M2 segment of the left middle cerebral artery shows filling defect, M2 and M3 segments.
Good. But
Which
started at M2 or started at distal M1?
distal M1. So,
Distal M1 before the bifurcation, because the bifurcation is the landmark of M2. Very good, very good, very good, my friend. So your diagnosis now and next step.
okay, so the diagnosis would be left MCA thrombosis
Good.
acute thrombosis, I would like to urgently inform the referring physician and alert the neuro interventional team
Good.
uh, to for and neurology team to decide between thrombolysis or mechanical thrombectomy.
Excellent. Excellent. The two ways of treatment, either a thrombectomy or thrombolysis.
Yes.
Actually, they choose the, thrombolysis, and the patient showed some changes on follow up. Let's see what happened here. Here, I want this one. I'm sorry, a thrombectomy, not thrombolysis, a thrombectomy.
Yes, sir. Okay. I've been provided with actual sections of the patient post thrombectomy status. There is hyperdense contents of blood attenuation in the left um,
Good.
frontoparieto-temporal region, and with significant mass effect with the form of compression of the left lateral ventricle, and no obvious midline shift seen, and there is subdural hemorrhage seen along the posterior
Yes.
mm, this thing, a
Good. Good.
posterior
Yes.
um, Fox, and
Good.
also there is at the region of okay, can I see at the region of MCA?
Okay.
Yes, so here I can see uh, probably contrast extravasation at this level.
So your explanation about this, what happened?
So post thrombectomy hemorrhage and due to uh,
Good, good. You
pro-
are suspecting hemorrhage. Good, good, my friend. Very good. I know it's a little bit difficult case. So I'll show you another case, then back to this one.
yes,
Okay? Okay. Again, as this patient suspected, remember, my friends, it's an important case. Suspected left hemiplegia. So you are looking at the right side.
right
Do you
side, yes, sir.
see anything?
So right, MCA hyperdensity.
Yes, very subtle
Yeah,
also. So
very sad.
suspected middle cerebral infarction, maybe loss of insular reponsign. It's important also.
Yes,
Here, the gray white matter is seen. Here, maybe early loss. And don't forget, my friends, the lentiform, and loss of lentiform or disappearing lentiform sign. Okay, on follow up after thrombolysis, not thrombectomy. Okay,
yes, sir.
what happened?
There is subarachnoid. There's um, hyperdense content of blood attenuation in along the cortical sulci of right frontoparieto-temporal lobes,
Good.
which could represent subarachnoid hemorrhage. Um,
Subarachnoid hemorrhage like this, a bulky like
uh,
this, or this is maybe parenchymal.
so parenchymal,
Yes,
yes, a parenchymal hemorrhage. Yes,
good.
right.
This continuous hyperdensities along
Yes.
the middle cerebral artery territory. So diagnosis,
So post thrombolysis. Uh,
even
uh,
without
com-
thrombolysis, if you see this pattern on a follow-up,
so
it's called hemorrhagic
hemorrhagic infarct.
transformation. Hemorrhagic
Hemorrhagic.
transformation, not hemorrhagic
Yes.
infarction from the start. Okay, unlike
Yes, sir.
venous. Venous
Yes.
infarction could be hemorrhagic from the start. Okay, but here along the middle cerebral artery territory, hemorrhagic hemorrhage within infarction less than 15%, and it occur
Yes.
after some time. So this is hemorrhagic transformation. It's
Trans-
clear. Okay, but what
yes.
about this one? This hyperdensities is continuous, not
Yes, sir.
disrupted, not discontinuous like this. This one spotty. It's a classic. It's a classic for hemorrhagic transformation. But this one is not. Looks like continuous. You said something about contrast extravasation.
Yes, sir.
So it
Sir,
is called, excellent, my friend, contrast staining.
okay.
Contrast staining. It mimics hemorrhagic transformation. Excellent, excellent. But still, the clinician want to differentiate. Is this hemorrhage or contrast extravasation? Anything to do?
Sir, I think
Maybe
the amount of if it was this much of bleed, then there would have been more mass effect and midline shift
good,
probably.
very good, very good. You see on
And
follow-up what happened? Increase the amount of density, but without significant increase in the edema pattern. And
yes,
again, very increased in density, very hyperdense and continuous.
yes, sir.
It's again contrast staining. The most recent item in differentiation is called dual energy CT scan. In a dual energy CT scan, okay, we use two X-ray tubes of different spectra. Okay, one of them, the usual one of them specially for iodine. Like what? Here it's
Yes,
called iodine map. Okay, adjusted to the spectrum of iodine. So anything related to the contrast media, it's iodine. Okay, will take a color. Okay, and this is the native screen, okay, or the native image. Then we can subtract. Then we can use subtract. And in the subtraction, it is called axial virtual non-contrast. This image is a virtual. If it is a hemorrhage, it will persist. If it is contrast staining, it will disappear in the virtual non-contrast image. You got it, my friend?
yes, sir. Yes.
Forgive me, this is difficult case. Okay. Okay. So hemorrhagic transformation, differential diagnosis. If intervention happened, it's called contrast staining. Thank you, Yabos. Thank you. Well done.
Thank you, sir. Thank you, sir.
Okay. Now, Dr. Ali, where is yes. Dr. Ali, how are you, Yabos?
I'm fine. Thank you.
Because I love you, you are my friend. I brought you a nice case. Okay.
Okay, but you
Okay.
have to scroll for me.
Okay. I see some difficulty. Okay, no problem.
Ah,
Elderly patient fall, then
okay.
loss of consciousness.
Conscious. Okay. I have been presented with axial images brain CT scan for an adult patient with history of fall and full loss of consciousness. I will scroll until the last cut of the images and then I will come back to my observation. I can see, okay, until the last cut.
Okay, my internet is not working well. Just a minute, my friends. Yeah, I will refresh. Okay. In a rapid way, elderly fall, loss of consciousness.
Consciousness. The main abnormality, I can see that there is large fronto, temporal, parietal, extraaxial, hyperdense hemorrhage is noted. This is associated with compression on the left lateral ventricle and shift of the midline structure to the right side. I
Good,
saw that there is also loss of Sarsai-Gyri differentiation
good.
within the left cerebellar hemisphere, indicating changes of brain edema. I can see that there is different densities noted within the extraaxial hematoma, representing different ages of subdural hematoma, which appears extending into the
Okay,
interhemispheric fissure.
very good, very good. What about different ages? The hypo density inside reflecting what?
The hypodensity inside representing very fresh unclotted blood.
Excellent, excellent.
Yes,
It's called a sign
uh,
called
pleural sign.
twirl sign. Excellent, excellent. Very good. And also
The subdural hematoma is seen extending into the interhemispheric fissure and also to the left tentorium cerebelli.
Very good. Very good.
Okay. Now
Why you choose the subdural, not epidural? Because
the subdural because first of all, it is not limited by the suture. It is
yes,
limited by the dural reflection in the
yes,
midline and
excellent,
extending
excellent,
into the midline.
excellent, excellent. So it's acute with added hyperacute element. So the patient in active bleeding.
Bleeding,
Active
yes.
bleeding with the swirl sign here, the hypodensity is a hyperacute blood. So the patient in active bleeding. Excellent. Okay. And you told me about the extension and some of the mass effects. Continue
Yes.
the mass effect.
Yes, the mass effect, I can see that there is severe compression onto the left lateral ventricle
Good.
associated with significant more than 3 centimeter shift of the midline structure into
Good.
the right side. In my routine practice, I want also to see the bone window to see if it is associated with bone fracture or not.
Okay. Any, just to remember,
Huh.
we have three emergencies in the brain, starting with letter H.
Yes, yes. Hemorrhage, hydrocephalus, and herniation. So I want to check if there is
Okay.
any evidence of
Yes.
hydrocephalus or herniation. I
What do
can
you
see that
see?
there is dilatation of the right lateral ventricle, which is
Good.
emergency. And in this case, I will pick up my phone and also contact with the neurosurgical team on call for
Good.
relieving this obstructive hydrocephalus. And also, I want to see the rest of the images to see if there is any other herniations also. And this is
Good.
subfalcine herniation.
Excellent. Excellent. Very good. Since we have a contralateral dilatation of the ventricle, definitely we have one type of, the commonest type of a herniation, which is called subfalcine
Subfalcine.
herniation. Very good. Any other herniation?
Yes, we have
For
which
example,
is
we have to
called.
look at,
Yes, we have to look at the foramen of magnum to see if
good,
there is a crowding of the foramen
which
of
is not
magnum.
good. So no
Yes, there
tonsillar
is no
herniation.
tonsillar
Very good.
herniation. Yes.
Any other areas of herniation or
Yes,
any?
yes. Could be. Yes. Here I can see that there is focal areas of hyperdensity noted within
Excellent.
the mid of the. Yes, and this could represent diurite hemorrhage.
Excellent.
Also, in the same area, I want to see if there is ankle herniation on both sides. I
What do
can
you see?
see that, yes, maybe on the right, no, but definitely there is no significant ankle herniation.
No, 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 no. An indirect sign. Where are the
Yeah,
subarachnoid spaces? Where are the perimesencephalic cisterns? It's an indirect
yes,
sign. Actually, the
yes,
uncus is herniated. Definitely, it's herniated. Diurite hemorrhage occurring with ankle herniation. So, complete effacement of the subarachnoid spaces, namely interpeduncular, suprasellar, ambient, suggesting the presence of ankle herniation with a complication by a diurite
of
hemorrhage.
diuretem. Yes.
Any explanation why diurite hemorrhage happened?
No, I don't have idea why
No problem,
diuretem.
no problem. Because of when uncus herniates the medial temporal loop, it compresses the vessels running in the perimesencephalic cistern, which is posterior cerebral and sometimes also basilar, and the branches from this, if compressed, it causes the
شكرا يا
diurite
دكتور.
hemorrhage.
Okay.
Just a
Okay.
minute. I will. Okay, I mute our friends. Okay, you can unmute yourself, Dr. Ali.
Yes.
Okay, okay, because one opens the mic, no problem. And also, it's important to be assessed in in the coronal. Okay, as the uncus herniate through the tentorium, and the tentorium leaflet, like falx, is very rigid, so arteries can be compressed. Subfalcine herniation, what is the expected vascular complication that may happen?
Compression onto the anterior cerebellar artery.
Excellent. Cerebral artery, yes, and may cause anterior or frontal, even bifrontal infarction. Excellent, my friend. So summarize, and don't forget also bone window.
Women window.
Summarize
Yes.
your case.
Yes, I have been presented with CT scan for a patient after falling down and loss of consciousness, presented with large left-sided subdural hemorrhage with
Good.
multiple phases indicating active hemorrhage and causing significant mass effect on the brain with subfalcine ankle herniation and right-sided lateral ventricle hydrocephalus and shifting of midline structure to the right side. And this is top emergency case, and I will
Excellent.
urgently communicate with the neurosurgical team.
Excellent. Excellent, my friend. Excellent. Okay, I wrote the name of the sign. Hyperdensity means acute. If any hypodensity within its center, it means hyperacute blood. It's called swirl sign. I write it in the chat. Swirl sign, it means active bleeding. The patient is bleeding now. So it's high emergency. H generally is hemorrhage, emergency. Hydrocephalus, H also is another emergency. But in this case, we don't need any shunt tube placement, just evacuation, okay, and relief of the pressure. Contralateral, if effacement of the ipsilateral ventricle and dilatation of the contralateral ventricle, it's a direct sign of subfalcine herniation. It's better to be assessed in a coronal, especially MRI because anatomical differentiation. Here, the cingulate gyrus will herniate. So it's called subfalcine or cingulate herniation, the commonest type of herniation. And if this is the temporal lobe, so definitely the uncus will be crossing the midline, okay? And it's compressed against the tentorium. It's another type of transtentorial herniation. And remember, tonsillar herniation can occur, but mainly with posterior fossa lesions. Excellent, Dr. Ali. Excellent. Well done, Yabus.
Thank you, sir.
Okay, the next candidate, I think easy case,
Assalamu alaikum,
inshallah.
sir.
Alaikum salam wa rahmatullahi wa barakatuh. How are you, my friend?
Alhamdulillah.
Okay, I will scroll for you and let's see.
Okay.
Yes, history. Suspected right-sided weakness. Okay. All cases stroke, no problem. It's a brain. Let's see.
Axial CT scan brain non-contrast study of a patient who has presented with right-sided weakness. I can see that there is no midline shift. There are small subcortical white matter hyperdense foci of variable sizes distributed in predominantly in bilateral frontal lobes and a larger focus noted in near vertex on
Good.
left side. So if you scroll it a bit more, yes,
Okay.
they are randomly scattered. There is no definite surrounding hypodensity to suggest edema. There is no associated mass effect. In rest of the brain, in the posterior fossa, I can see there is no midline shift.
Good.
And gray and white matter differentiation is preserved. There is also hyperdensity in right temporal periventricular white
Yes.
matter.
Excellent.
So there are multiple hyperdense foci of variable sizes, predominantly at gray-white matter junction in the region of subcortical white matter. Considering random distribution and without any definite mass effect, I will include differential possibilities. In my routine practice, I will measure the Hounsfield units to confirm
Good.
whether these are areas of calcifications or hemorrhages.
Good point.
And if apparently some of them are relatively more hyperdense, more in favor of calcifications.
Good.
And can be multiple calcified cavernomas or
Excellent. Excellent.
as the
Because
patient has acutely presented.
when you said gray white matter, I think you will say diffuse axonal injury as a first diagnosis. So it's better to say very good, calcified, so it's cavernomas.
Yes.
Gray white matter junction is highly specific for diffuse axonal
Diffuse
injury,
axon,
but
yes.
no history of
Yes.
trauma. Just and it's a history of trauma is important, and also the patient will be in ICU in
Yes.
case of diffuse axonal injury. Very good, my
Yes.
friend. So maybe just diffuse, multiple cavernomas, okay, scattered. What you will do next?
I will compare it with previous images if available. And as
Good.
the patient has presented acutely, there can be a chance of some recent hemorrhage in any of these
Good.
lesions, as I could see one larger lesion in left posterior hyperrital lobe.
Yes,
And
yes, that's very good. This one maybe
and I can
logical.
also
Good.
assess this on MRI. to look
Good.
for different.
And don't forget, just routinely in my routine practice, I will check other planes and bone window. Okay.
Yes, yes.
Okay. Which sequence you want to see on MRI?
I will look for T1 and T2. There are multiple variable sizes. Again, I can have the same observation. They are hyperintense in same distribution with surrounding hemosiderin signal void rim. And I want to have a look if there is any edema associated with them. The right temporal lesion has no edema around it, no mass effect.
Sign.
And
Any sign here?
the popcorn sign appearance.
Good, good. Okay, it's not class, but we have a low hemosiderin rim.
Yes, yes,
Good,
hemosiderin rim.
good, good.
Yes.
Hemosiderin rim is very
Yes.
important because lesions with low T2 signal are very few. Most lesions will be high on T2, but very few lesions will show a low signal on T2. Okay, what is the next sequence? You said T1 and the T2.
SWI.
Yes, yes, my friend. Yes, SWI is very important to determine the true extent of these lesions.
Yes,
Very
there are
good.
multiple innumerable
Yes.
variable sized areas of blooming noted in brain randomly scattered. So these
What
confirm
about
my
this
diagnosis
area?
of.
What
They are
about this?
symmetrically signal void in basal ganglia and the region of lentiform nuclei, likely calcifications.
It's blooming
Which
also. So this
yes,
lesion may be cavernoma blooming, and this may be calcification bloom. How to differentiate if this is
by
cavernoma
the
or
phase,
calcification?
by the next sequence, which is
Excellent, excellent. What is the name of this one? It's
phase.
called, yes,
It's phase
phase contrast. Yes, phase
contrast. Yes, phase
contrast
contrast. Yes.
sequence. Okay, it will be the opposite of blood. The opposite of blood, if a calcification.
Yes.
And in case
Yes.
of blood, usually following the signal of vessels. What about
Yes.
high signal or dark signal? It differs according the type of machine, with a
Yes.
right-sided machine or left-sided machine, يعني GE
Yes.
or Siemens. Very good, my friend.
Yes.
So your diagnosis,
Multiple cavernomas with
any
differential of
underlying
yes.
syndrome,
Um,
multiple familial cavernoma
multiple
syndrome.
familial
It's
cavernoma
familial.
syndrome. Yes.
Good,
Yes.
good. Any other cause of multiple cavernoma? Patient has previous intervention. What could be?
Previous intervention for any
Previous
what type of
intervention in the head and the neck many years ago. What could be? What may induce the formation of cavernomas?
okay.
Okay,
So post-intervention cavernomas.
patient has treated head and neck cancer. Any relation?
It could be post-radiotherapy or
Excellent, excellent. Yes, yes, yes. Post radiotherapy. Very good, my friend. Radiotherapy can induce cavernomas. It can induce also meningiomas. Very good, my friend. Very good. Excellent. يا boss. Excellent. Okay.